Hi, I'm Rick Olderman, physical therapist and author of my recent book, Pain Patterns. Today I'm answering real pain questions from real individuals in pain I've received recently. But before we get started, I want to explain something crucial. Why so many people are still stuck in pain despite trying everything under the sun. Most treatments approach pain with what I call a component approach, testing to find which tissue seems damaged, whether it's muscle, tendon, disc, ligament, nerve, or bone. The treatment then focuses on calming or fixing that tissue with things like dry needling, massage, e-stim, manipulation, hot or cold pack, TENS units, cortisone injections, strengthening or stretching that tissue, or even surgery. This works very well for acute problems, and in fact, most tissues should naturally heal in about 3 months using these treatments. But it does not work well for chronic problems, which is the common denominator for nearly all of the questions I receive. Chronic pain requires a systems approach understanding of how the body is connected and how stress from one area can damage tissues somewhere else. The key isn't just treating the sore spot, it's testing your body to see where your system is breaking down. Fixing that system problem often resolves pain in multiple areas at once. For example, if your hip joint doesn't track properly, it doesn't just cause hip pain, it can trigger back pain, sciatic pain, SI joint issues, bursitis, piriformis problems, groin strain, IT band irritation, knee pain, and even foot pain. But once you correct that hip tracking, all of those issues can resolve together. That's the beauty of a systems approach. To make this easier, I've broken your questions into 5 groups: back, hip, knee, foot, and upper body. And then finally, I answer a question about fibromyalgia. Because I'm addressing systems problems, if your question happens to be one of the first answers, I strongly recommend listening to the other groups too. Often, even if your pain is in the upper body, it's linked to issues in the lower body, and the details I cover across groups may be the missing piece for you because this is about understanding and fixing your body as a system. All right, with that foundation in place, let's dive in and start answering your questions. So Darlene asks, what is the best exercise for shoulder and neck pain? And then William asks, I am experiencing severe pain in my hands, a burning sensation. What might be the cause and how might I treat it? Well, first of all, William, I'm hoping that if you have pain in both of your hands, that you have seen a doctor and a neurosurgeon to evaluate your spine. If there is pain happening in both sides of the upper body at the same time or lower body at the same time, I tend to think that there is a central problem going on involving the spine, like a disc herniation, bulge, or something happening at the spinal level, because something happening centrally then can radiate into both hands. So please get checked out by a neurologist to confirm or to rule out a more serious problem at the spinal level. Now, if pain is happening in one side of the body or the other, then I tend to believe that there is a biomechanical issue going on here, one that we can fix through how you're using your body, strengthening or stretching in some way. To answer both of these questions, it's important to understand how the upper body system works. The center of the upper body system is the shoulder blade. They are broad, flat bones. They have significant muscular attachments into the neck and the base of the skull and the shoulders and arms. So it's important to understand that usually most chronic pain problems involving the upper body, like chronic shoulder, neck pain, or headaches, involves the shoulder blades. Now there are rules about how the shoulder blade can rest and move. I'm not going to go into those rules. I've covered those in my Fixing You books for shoulder pain and neck pain and headaches. You can read those if you want to, but basically know that there are rules and that most people with chronic pain are breaking some of those rules. The most common thing that is occurring with most chronic neck, shoulder, and headache pain, and even possibly bilateral hand pain, like Williams, is that the shoulder blades are resting too low. And so there's a really easy test to determine if this is occurring in you. That is, first of all, you move your head back and forth, up and down, and note the range of motion at which you have pain and the degree of pain that you have. Really dial that in so you can be very specific with that. If you have shoulder pain, do the same. Move your arm around and see at what angle it hurts and at what pain level it is. If you're William, then you'll want to notice whether turning your head is causing more or less hand pain. All right, so let's say you've figured all of that out, and now we're going to go into the test. I call it the armpit test, and it's very effective for figuring this out. So now that you've figured that out, you're going to have a friend come up behind you, and they're going to put their hands in your armpits like this, and they're going to lift up your shoulders about an inch higher than normal. Your job is to relax your shoulders into their hands as much as you can. Make them as heavy as possible. And then after about 15 seconds of this, what you're going to do is move your head back and forth, up and down, and see if you have greater range of motion in any of those motions, or if you have less pain in any of those motions. In fact, most people with what I call depressed shoulders feel an instant relief when this test is being done. So you're going to notice whether you can move your head more before pain happens or whether pain is happening less. And then after about 30 or 60 seconds, that person is going to lower your shoulders back down, and you can retest again to see whether your pain has returned. Usually it'll return in 30 to 60 seconds, something like that. So what is this test telling us? The test is telling us, especially if you've been told that you have disc bulges, herniations, arthritic changes in your spine, nerve root impingement, all sorts of things that are causing your neck pain, headaches, or shoulder issues. If lifting the shoulder blades reduces your pain, especially in just the 30 or 60 seconds that you did this test, then this is telling you that the shoulder system has a problem that is stressing your neck, your head, or your shoulders. What is that problem? Well, part of the problem, at least, is that your shoulder blades are resting too low. And so this is what I call having depressed shoulders. This is a very common condition, especially for people who have engaged with dance training, gymnastics. They do a lot of yoga, they do a lot of Pilates. Why is this? Because in those disciplines, the aesthetic of having a long neck is emphasized. And in order to create a long neck, you are trained to put your shoulder blades down and back into your back pockets. This depresses the shoulders and makes it look like the neck is longer, which is an aesthetic value, but it's not a functional value. So your pain is telling you that this is not good for you. This is why you're having chronic pain. What is an easy exercise to start getting started on this and reversing this? I call it the all fours rocking exercise. You're basically going to get on your hands and knees and rock back onto your heels so that your hands remain up over your head. You can even slide the hands forward more when you do this. And then you can walk the hands over to one side and walk the hands over to the other. And what you will feel is a big stretch in the shoulder system and possibly the rib cage as well. What you're doing is you're stretching the muscles that are depressing the shoulder blades. And you should be able to get up from that stretch and feel that your pain almost feels instantly better, whether it's headache, neck pain, or shoulder pain. So this would be a good one to do for you. And then of course we have to change your posture strategy, because likely what you're doing is continually pulling your shoulder blades down in your back posture to make it look like you have an erect posture. So let's go over that really quickly too. So the correct way to create good posture is simply you put one hand on your chest and your other hand on your belly. Take a deep breath. And you'll feel that your rib cage lifts. And then exhale, and your rib cage lowers again. So this time we're going to take another breath. The rib cage lifts, and this time when you exhale, you can exhale all the way, but don't let the rib cage fall all the way. And keeping your rib cage up just a little teeny tiny bit, you'll feel that your stomach muscles have just engaged. This is your core holding up your upper body system. This is why we have so many layers of core and that they are so huge. They need to be able to hold up this whole system. Notice I didn't ask you to contract your core muscles. The core will activate as much as necessary to hold your posture in an ideal position. All right, that's a really important point. Now, the second part of this is that you need now to bring your arms down by your sides, loosen up your shoulders, roll them around, get them to turn off, and your arms should be like two dangling ropes sitting by your sides. Now you'll notice that when you relax your arms fully, you've just lost the core activation of holding up your rib cage. This is because you've tied your posture strategy to squeezing the shoulders back instead of using your core. And that needs to be decoupled and retrained. And this is how you do it. So hopefully that helps both Darlene and William begin to understand what could possibly be going wrong with their upper body system, causing their chronic shoulder, neck pain, headaches, and hand numbness in both hands. Okay, this next question is from Beth. Beth is 67 years old who has had flat feet all her life and was diagnosed with a double S-shaped scoliosis curve in her back about 2 years ago. She has an ankle foot surgery coming up in early September since her foot is very pronated and creates a very uneven gait when she walks. She says, I cannot stand more than 5 minutes before lower back pain begins and worsens until I get off my feet. Between daily exercises, water therapy, orthotics, and periodic wearing of a custom back brace, my spine remains stable in that the scoliosis cob angles have not worsened in 2 years and are slightly better when I wear the back brace. Do you think this foot surgery can improve my back pain and scoliosis related back and sciatic pain symptoms? My ortho surgeon feels he can reduce ankle, foot, and radiating leg pain about 70 to 80%. Not looking forward to the surgery, but getting to a hopefully better pain management level. Thanks for your response. All right, Beth, so let's talk about this foot issue. So the interesting thing that I picked up in your question is that you say, do you think this foot surgery can improve my back pain? So to me, it sounds like you're planning on having surgery in just one of your feet. I don't know for sure. I'm not clear on what you've given me. I get very nervous about foot surgeries because they are so complicated, and I haven't seen many that people were very happy with. Now, I don't know the type of surgery you're about to have. I don't know anything else about what your surgeon is finding, and the surgery may be completely appropriate. However, I find that if your pain is happening from standing because of a pronated foot, at the risk of going against what your surgeon says, I believe that there are many other things that you can likely correct to fix your back pain other than fixing your foot pronation. The foot pronation may be part of the problem, but it's how your body is compensating around that foot that is the real problem for you. In my home program, I have a foot taping technique that is very simple. It uses one piece of tape that tapes up the arch of the foot. And the reason I like this is because it is a very specific correction of the foot and ankle. And at the risk of sounding like I'm just trying to sell you something, I would really, if you were coming in to see me, that is the taping technique I would do with you first to see how that plays out at your knee, hip, pelvis, and low back. I can almost guarantee that by simply taping the foot up in a better position, this will help reduce your symptoms. But we not only have to focus on the foot, you're correct in knowing that the foot is affecting everything up the chain, including your back. But let's say that we tape and correct that foot. What happens then to all of the compensations that you've learned to do over your 67 years old, so the last, let's say, 50 or 60 years, because of having a flat foot? Because the flat foot didn't just occur likely in the past couple of years. It's probably been happening for decades. So we would need to understand the changes that have happened up here that are causing your back pain in order to truly fix your back pain. It's I think, a dangerous idea to think that if we just fix the foot, that will solve the whole thing, because your brain has learned to compensate around that foot pronation. That would be my answer, is I would try taping up this arch in this particular way I developed that specifically lifts the arch significantly and, most importantly, precisely corrects the foot and ankle. What I have found with foot pronation is that it's not just the foot that becomes flat. Usually the ankle is falling along. And so what happens is we not only need to control the foot arch, but we need to control how that ankle meets the foot in order to start fixing the issues that are occurring up the chain. That's just my impression from what I've read here, is that this is really a gait compensation issue that's happening, that's surrounding a flat foot, rather than just a pure problem that is happening because of your foot. And I hope that you listen to the rest of this video, because I'm going to be going into other things at the hip that are likely contributing to your back, and I think this will give you a lot more input. So please stay tuned for the rest of this video. All right, Kathleen asks, I had arthroscopic surgery on my left knee several years ago, 6 incisions, which resulted in tightness and decreased flexibility with bending that leg compared to my other leg. I am unable to get anywhere near sitting on my heels, but can place my hands on the floor with straight legs. About 1 week ago, I tweaked that leg and now have even less flexibility and some pain in the back of my knee when I try to bend it enough to get in and out of a kayak, or try to push my foot back under a chair or cross my ankle on the other knee. There is no swelling or redness or bruising and no difficulty with walking. I think massage and rolling help a bit, but wondered if you have any other suggestions. And then the other knee question is from Lucy. How long does a dislocated knee take to heal? Are there any specific stretches and straighteners, I'm going to guess strengthening exercises, that can help? Her knee was dislocated laterally, apart from resting, ice, compression, and elevation. I have seen a lot of people with knee issues, and one of the things we have to do as physical therapists is get knee range of motion back after surgeries and accidents and so forth. I found what seems to be a miracle cure for a lot of knee restricted range of motion. And I mentioned this in my book, Solving the Pain Puzzle. I actually had a guy fly in from New York who hadn't been able to straighten his knee for years and had been to everyone. We straightened it in about 10 minutes doing this little maneuver. On the other end of the spectrum, I once had a guy who had a complete reconstruction of his knee from a really nasty accident, and it was his first visit, and we gained 15 degrees of knee bending by addressing this muscle that I'm going to be talking to you about right now. So there's a secret muscle, apparently, in the back of the knee called the popliteus muscle. It runs from the inside of the knee to the outside of the thigh bone. All right, so it runs from the lower leg bone on the inside to the outer part of the thigh bone on the outside. The bulk of the muscle is on the inside of the knee, and after it gets to about the center of the knee, when it crosses, it becomes more like a tendon. Why is this muscle so important? Well, this muscle tends to go into spasm after surgeries or trauma like a dislocated knee. And so what happens is, because this popliteus muscle crosses the knee joint going up and down and medial to lateral, it controls rotation of the knee joint. All right, so if the muscle is in spasm, it seems like it's locking the knee into a rotated position, which then restricts range of motion in both directions. And in terms of the dislocated knee that Lucy has, if the knee is locked into a medially rotated position, then the IT band, which is blending into the kneecap, is trying to pull that kneecap out excessively as a result. And so if we release the popliteus muscle, that will allow the knee to rotate where it's supposed to and may reduce a lot of that lateral dislocation pain, but it also may allow the knee to bend significantly more. All right, now with knee dislocations, one of the reasons that this is also happening is you can see this ridge on the outside of the thigh bone here. And when that ridge is too low, it doesn't prevent the kneecap from slipping on the other side of it. So Lucy, I'm not sure if you have a ridge that's too low on top of this. Even if you do, that means that we have to look even more closely at anything that could possibly be pulling that kneecap out, such as a rotated lower leg bone that relatively causes the kneecap to drift to the outside, tight IT band, tight lateral quad muscles, things like that. Even femoral anteversion, which I'm going to be going into in the hip section of this video. All right, so how do we release the popliteus muscle? Well, not to sound like I'm trying to sell you something, but I've got that in my home video programs for hip and knee issues, but it's really simple. Basically, you're going to lie on a table, and it's best if someone else does this for you. So frankly, just find a massage therapist or a physical therapist and ask them to please massage your popliteus muscle. If they are massaging on the outside of your knee, then they don't know how to massage a popliteus muscle. They should be focusing more on the inside of the knee towards the center of the knee and roughly below the knee. So the bulk of the muscle is down here on the tibia area, and after it crosses the knee joint, then it becomes more tendon. So they should be focusing on here. And this will be exquisitely tender for a lot of you with chronic knee issues. And so what they should be using is the flat part of their fingers, not the bony, ends of the fingers, because you're going to jump off the roof. You're going to jump off the table and hit the roof if they do that. So they should be doing it in circular, gentle motions, gradually going deeper and deeper as this releases. And then what you'll do, it should take maybe 5 or 10 minutes of that, and then get up off the table, walk around, and you will probably feel that your knee immediately feels looser and freer in movement. And then you can test your range of motion to see whether you can bend that knee more. And if you can, then get back up on the table and have some more massage. So, of course, the knee is kind of caught between the foot and the hip. And these two, the foot and the hip, have a lot to do with what is happening at the knee. So the popliteus may not be the only thing that's going on here, but it's usually one of the big things when I see knee pain. So one of the other things, like I mentioned before with Lucy, is femoral anteversion and retroversion have a lot to do with what's going on at the knee, and I'm going to talk about that more in the hip section of this video. So I hope that gives you a way to move forward with this, both of you, and please listen further for more detail. Okay, so our first question comes from Jennifer. How do you correct chronic anterior pelvic tilt despite daily working on right side psoas, iliacus, piriformis, and gluteal muscles? I'm unable to find a practitioner of any type to help me find the cause of my chronic gluteal pain. Everyone wants to do an injection in my SI joint, but I believe it is muscles. Then Kathy asks, why do you develop groin pain and how do you fix it? And then Laura asks, my doctor said my hip pain and sciatic issue, numbness in the toes, is due to a tight piriformis. What exercises would you recommend for this? How many reps and how often? Should I have a regime that I do every day for the rest of my life? I have been dealing with these issues for about 20 years. I am 73 years old, do yoga, cardio, and strength training every day. Good for you, Laura. Luann asks, I would like to know about how hip bursitis actually develops and how an active person can get bursitis despite being active. I have heard that the bursa actually doesn't get inflamed, but other tissues surrounding it do. Kathy asks, how long is the recovery for gluteal tendinopathy? I've had this chronic pain for 2 years, was misdiagnosed for about 6 months until I requested an MRI. I have read about shockwave therapy, as far as I know, done by chiropractors. What do you think of it? I am a ballroom dancer. Do I have to give up dancing in order to heal this? And if I do heal it, can I go back to dancing? I am otherwise a very healthy 78-year-old. Good for you, Kathy. Jane asks, have you any tips for living with and managing FAI, which is femoral acetabular impingement syndrome, with GTPS, which is greater trochanter pain syndrome? Would you recommend corticosteroid injections or surgery? Finally, Jada asks, What can be done to try to relieve the searing pain that radiates from cluneal compression? The cluneal nerves are the nerves that come off of the iliac crest and feed into the butt muscles here. It affects my entire left leg, especially the glutes, which will not turn on and are weak. It also causes me to have a twist and leaning stance in the torso. I have attended physical therapy twice for this condition. So all of these questions, of course, have to do with the hip joint, but this is a great way for me to kind of explore the hip joint, especially for those people in the next series of questions, which is about back pain, because the hip has a lot to do with back pain, sciatic pain, and so forth. Okay, so what's going on here? Well, there's a lot of, as you can see, there's a lot of different types of questions with a lot of different tissues that are irritated and so forth. So let's just talk about how the hip works. All right, so the hip joint is in the socket like this, and when we walk, it should be pivoting in the socket nicely in order to have good tracking and so forth. When the hip doesn't have good tracking, the most common aberration is that the thigh bone is migrating forward in the hip socket. This is a condition called anterior femoral glide syndrome, and I've made a YouTube video. I've talked about it in my books. So anyway, anterior femoral glide syndrome simply means, anterior means forward, femoral, it's gliding, and it's a syndrome, which means that there's a cluster of symptoms that are associated with this, but also a cluster of reasons it's occurring in the first place. All right, so the symptoms that this condition creates is groin pain, which is what Kathy asked about, and it's creating groin pain because the femur is migrating forward in the hip socket. Now, if you have a femoral acetabular impingement syndrome, which means that the front of this acetabulum, where the socket is usually thickened, then if you have a glide syndrome, that femur head is bumping into that FAI, or femoral acetabular impingement syndrome, causing pain. This can also, because it's careening around in the hip socket like a washing machine that's out of balance, it can also create labral tears in the hip. All right? Often the labral pain is felt in the front of the hip too. Because the psoas muscle comes down from the spine and inserts into the front of the thigh bone here, when this migrates forward, it can also irritate the psoas muscle. There's a bursa on the outside of the hip bone here, and it is between the IT band, which starts up here on the crest, which goes down to the knee. And so the bursa helps lubricate the motion of the thigh bone against the IT band. If the thigh bone is not in the correct position, as in an anterior femoral glide syndrome, then that creates bursa or bursitis symptoms and greater trochanteric pain syndrome on the tip of the bone. All right? So hopefully you all are seeing that all of this is connected. All right? So finally, when this is happening, we have a teeny tiny piriformis muscle that runs from the sacrum to the hip bone. It's like a pinky muscle. And so that little pinky muscle is holding onto that femur head, trying to pull it back in the socket because the larger gluteal maximus muscles are not doing their job. So that then causes the piriformis syndrome to occur. In 30% of the population, the sciatic nerve pierces the piriformis, and in the other 70%, it runs underneath the piriformis muscle. And so this is why the piriformis gets irritated and can contribute to sciatic pain. But it's not the piriformis's fault. It's because the thigh bone is migrating forward in the hip socket, and this is all occurring because the butt muscle is not working correctly. Lastly, because this hip bone is careening around in the hip socket, it can cause global arthritic pain in the hip, too. I've helped a lot of people avoid hip replacement surgeries by simply correcting the anterior femoral glide syndrome, which removes almost all of their hip pain that they're having the surgery for. The key is that the gluteus maximus needs to turn on correctly. It runs from the sacrum to the thigh bone, just like the piriformis. And so I think of it as a big hand muscle. It's powerful. It's one of the strongest muscles in the body. It's designed to be working 24/7. And if this muscle is not turned on, then the little teeny tiny muscles deep to it, one of which is the piriformis, the obturators, the gemelli, and so forth, those guys have to work super hard to make up for this big granddaddy of a muscle that isn't doing its job. That's what's behind almost all hip issues. Why isn't the butt muscle turning on? So the butt muscle is not turning on usually because of how you're walking. And what is happening when you're standing and walking is that your knee is locking straight. And when this occurs, it turns off the butt muscles. So I'm going to step back here and demonstrate what is typically going on with gait and then how to simply correct it. But before I think I do that, I'm going to get you to actually test your butt muscle to see whether it is turning on this side. So what we're going to do, it's a simple test. You're going to put your fingertips on your butt muscle, not at the bottom, not at the top, not out here, right in the center of the meat of your butt muscle, right there, and dig the fingertips in there so you know that they're there. Okay, now what you're going to do is you're going to pinch both butt cheeks together, and you're going to see whether both butt muscles contract at the same time and to the same degree. If you're not sure, relax them and pinch them again. Most people with pain on the side of the hip that's painful will find that their butt muscle doesn't seem to be contracting as much or later than the other side. Now, the other thing that you want to do is when you relax them, notice whether both butt muscles relax at the same time too. Okay, so now you have an idea of what the butt muscle feels like when it's contracting. Now you're going to keep your fingertips on your butt and you're going to walk maybe 10 or 15 steps and you're going to see if you feel any of that contraction happening when you're walking. I can almost guarantee that if you have chronic hip issues, you will not feel your butt muscle engaging very much at all. Please confirm that. Now, let's say that you have confirmed that. How are we going to fix this? Well, we're going to go up on your tippy toes and you're going to walk around again for 10 or 15 steps. And I want you to see whether you feel that butt muscle turning on more now while you're on your tippy toes than when your feet were flat. If it is, keep walking on your tippy toes and now slowly lower your heels while you're walking and see if your butt muscle stays turned on now even though your heels are back down on the floor. For most people, the butt muscles will stay turned on for another 5 or 10 steps at least. What's going on here? Why would tiptoe walking solve or turn on the butt when your normal walking isn't? Here's the problem. What is going on with normal walking for most people is that they are advancing their foot in front of them while the body remains behind them. And we do this because the thick heels on our tennis shoes and so forth allow us to have a nice firm heel strike like this. All right, so what does this do? Well, when we strike the heel like that, the knee locks in a straight position, which then signals the butt muscle to turn off. And now it's turned off as we pass over the foot. This is exactly when the butt muscle needs to be on, is when we're over that foot. And now it's off because the knee is locking. And the knee is locking because of the foot coming out in front of the body. So what tiptoe walking is doing is simply forcing you not to land with your foot in front of your body. It's impossible to walk on tiptoes and have your body behind you when you're stepping. It just can't be done. So this is fixing that, and you've just found that is automatically turning on your butt muscles without you even thinking about it. All right, so why is the tiptoe walking doing that? Well, what it's really doing is it's forcing your body to move forward with the advancing foot. When this occurs, it's almost impossible to lock your knee. In fact, if you walk on tippy toes, you'll notice that you cannot do that while locking your knees straight. This is a key idea that you need to grasp if you have chronic hip, knee, foot, or even back pain. All right, so basically the tiptoe walking is forcing your body to move forward with the advancing foot instead of your foot coming forward without your body. So the way I get people to practice this is every time they stand up from a chair, anytime during the day, your first 5 to 10 steps should be tiptoe walking. This will force you to correct your gait pattern immediately upon standing, and then you can lower the heels down. Now, a lot of people will be like, but I don't know if I'm doing it right. You will know if you're doing it right if you simply put your fingers on your butt muscles and you feel that they are activating. They should be activating about 5 to 10% of your maximum contraction that you felt at the very beginning of this testing. If you feel that butt muscle is working, then you are walking correctly. All right, so it's that simple. So what does walking with your body advancing with your foot look like? It looks just like this. It's a perfectly normal looking walk. But in your brain, because you've been walking with your foot coming in front of you, it's going to feel like a completely abnormal walk. In this case, normal is what is hurting you, and you have to start walking abnormally to fix this old habitual problem. So there's one other idea I want to emphasize with you about all of this, and that is that the shape of the thigh bone has a lot to do with whether you're having hip, knee, back, or whatever pain. Thigh bones can be twisted inward, and this is called anteversion. It's not an anomaly. Everyone has some degree of anteversion or the opposite, retroversion, where it's twisted to the outside. Men typically have retroverted femurs, which means that their thigh bones are rotated out, and women typically have anteverted femurs. However, women can have retroverted and men can have anteverted, and somebody can have one retroverted and one anteverted femur, and you can have any number of possibilities of this. I show how to test this on my video here on my YouTube channel, so you can decide whether you have anteversion or retroversion. So here's the deal. If you have anteverted femurs, ones where the thigh bone is twisted in, the hip and knee joints do not like internal rotation. So if you have anteverted femurs, you need to have even stronger butt muscles, which are external rotators of the thigh bone, when you're walking, exercising, and so forth, to control the internal rotation that's naturally built into your thigh bone shape. So for the woman, I can't remember her name, who had a pronated foot at the beginning of this and was looking at surgery, I wonder if you have an anteverted femur that is rotating in, that is helping to pronate that foot. Because if that femur is uncontrolled as it rotates in, that means that the foot is pronating excessively too. This could be the thing that's causing the foot to pronate excessively. This is why I'm nervous about the foot surgery, because there are many other things that could be going on here. If you're a man and you have retroverted femurs, what we are conditioned to think as men is that our feet should be pointed straight when we're standing and walking. If that's the case, then your thigh bone is relatively internally rotated, because your foot position is not matching the shape of your thigh bone. If your foot was matching the shape of your thigh bone, it would be pointed out, just like your thigh bone is. And so if your foot is pointed in, then you are suffering from chronic internal rotation of the thigh bone, which increases compression in the hip joint and breaks down these tissues. This is a really big concept that I test in every single one of my patients with anything from back pain all the way down to foot pain, because the shape of the thigh bone is critical. I mentioned this in my pain patterns book. I have this in my home programs. I have it in my hip and knee pain book. I've made that YouTube video. Here it is again. If you want to test yourself, it is critical to understand this shape and what it means. And almost no practitioners ever test for it or even understand it, much less understand how to use your body with a condition like this. So for those of you, again, who have an anteverted femur, you will need stronger butt muscles, which means a better walking pattern than most. And if you have retroverted femurs, you need to start turning your feet out a little bit to match the shape of your thigh bone, which will instantly free up your whole leg system to work better, and your hip. So having said all that, and now learning that walking correctly is the key to turning on the butt muscle, the one exercise that I found that is the most effective at turning on the butt muscle and reconnecting the brain back to the butt is something that I call the butt pump, which I feature in my programs, in my book, and in basically anything that I ever do, I talk about the butt pump. The key for the butt pump is to have the leg in a position that you feel the butt is controlling the movement of the leg up and down. And so 2 sets of 30 repetitions of butt pumps helps turn it on. Now what I found is that during the course of doing those butt pumps, if you stop feeling your butt doing the exercise, then that means that the butt has fatigued and it's done. At that point, stop the exercise. Even if you're on rep number 3, you need to stop, because otherwise you're just training the other muscles to do the work for it, which has been what's going on for all of this time anyway. Build up to that 30 reps, do it correctly, and I truly believe that you will be really happy that you did, that it will give you the relief that you're looking for a lot of this hip issue, especially if you combine that with learning how to walk correctly. Hopefully, this has given you some new information about your hip and why maybe you can't ever seem to turn on your glutes, and why turning on the glutes is important, and all of these other hip pain conditions that you've been experiencing. All right, so far I've been talking a lot about the lower body system. We're about to get into the back pain questions. So I just wanted to let you know that everything that's in this video, starting at the feet all the way up to when we get to the back pain issue, is found in my Pain Patterns book. The second half of that book serves as a workbook. I have all the tests and how to interpret the tests and the exercises to correct all of these issues. All of these tests and exercises can be found as videos on my rickolderman.com website. So I would strongly recommend that you get the book if you're wrestling with pain and want to finally see how all of this works together. Now, for those of you who are still doubtful or don't want to buy my book, I have created a Pain Patterns video series on my YouTube channel. It's free, and it covers all of these tests. It shows you exactly how to do them, and so you can test yourself without paying a penny. I strongly recommend that you watch the videos from video 1, and this is the first one. It's about chronic pain, and go through each video of each chapter. They're only about 5 minutes long, but you will learn about your body in a new way that you likely haven't heard of before. And the testing videos in this series will help you understand what you're missing from a systems standpoint. So I can't encourage you more strongly to please explore those, as well as all of my other videos on YouTube. I mean, I've made so many videos to help people figure out why they're having pain and therefore know how to solve it. So please look through all of that information. Okay, this question is from Rochelle. I understand that you are not able to give medical advice. However, would you please offer me some direction if you are able? I am only 56 and have the most debilitating sciatica in the world. Truly. I cannot stand for more than 5 to 10 minutes without sitting down. Laying and sitting help. I also have spondylolisthesis grade 2 and severe stenosis. This has been going on for 4 years, and I have had ESI, PT, chiro, MRI, stretching and strengthening, and more stretching. I have tried Lyrica and gabapentin. I have been told I need a fusion and laminectomy. I am fighting this until I am on the ground and can't walk. I am a pharmaceutical rep and have been driving 2 to 3 hours a day for 30 years. Weirdly, my low back does not hurt as much as it did before. The pain starts in my buttocks area and goes all the way down to my ankles. Can you please help and provide some direction with the sciatica issue? All right, the next question is from Pat. Can I handle spondylolisthesis without surgery? So that's 2 spondylolisthesis so far. So let me just take a break here and tell you what spondylolisthesis is. So basically, spondylolisthesis is not only difficult to pronounce and spell, but it is a fracture in the vertebrae here that then allows the vertebrae above the vertebrae to slide forward, and that ends up pinching the spinal column and the nerve roots exiting the spine. Spondylolisthesis can be a naturally occurring phenomenon, especially if you've been involved with a lot of, for instance, jumping sports or collision sports as a young person. These people have suffered usually spondylolisthesis, and they have no pain at all until they start to develop pain and they take an x-ray and find that there's a fracture in the spine. So there are different grades of spondylolisthesis. I have seen an image, I'll try and put it up here for you, of a person with a grade 5 spondylolisthesis. You can see that the vertebrae is almost completely off the vertebra below it and almost completely pinching the spinal column. And guess what? This person had no pain whatsoever. So just because you have a spondylolisthesis doesn't mean that you need to have pain. It just means you need to understand how to manage the forces acting on your spine, which is what we're going to be going over in this part of the video soon. Let's go down to Trudy's question. I have a couple of bulging discs, stenosis, and arthritis in L4-5. I could send an MRI report. No thanks, Trudy. I had 2 laminectomies in the late 80s. Recently, I am having spasms higher up in my back that hurt very bad, and I don't know what's causing them or what to do. I am 73. Try to stay active and avoid processed food. Notice my posture is hunching forward too. So this is the second mention of spinal stenosis. So I'm going to talk a little bit about that briefly. Spinal stenosis, so the spinal cord goes through a hole that's in our backbones, our vertebrae, and through this, it's a spinal canal. And so stenosis just means that bone is encroaching in that spinal canal on the stenosis. So it's getting thicker and thicker in there and pinching the spinal cord. So that is spinal stenosis. And of course there are grades, mild, medium, severe, and so forth. Okay, so the next question is from Jefferson. Can I do your set of exercises after a microdiscectomy operation? Are there any kind of exercises I should not do because of this operation? I still have some minimal pain after the surgery and don't want to go through another operation. Thanks. So Jefferson, just quickly addressing this, I cannot understand anything about your back based on this information. And because you've just had microdiscectomy, this is a question for your surgeon or your physical therapist that you're working with after your microdiscectomy. Hopefully you are working with a physical therapist after that. And so please post these questions to them. If you have purchased my back pain program or purchased my pain patterns book and want to do those exercises, just bring those into your physical therapist and ask them, hey, look over these and tell me which ones are good, which ones I can't do right now, and if I can't do them, please tell me when. So that's the best I can do to answer your question about, your post-surgical movement. I really don't know anything else about you, and I can't responsibly give you any more advice about that. But please listen to what I'm going to talk about, so this may help guide you as to how to think about what to do moving forward. All right, Dale asks, MRI shows spinal stenosis, that's the number 3. Trying to avoid surgery, have been doing PT for some time, core strengthening, stretching, hamstrings, hip flexors, and piriformis. Neurosurgeon recommended shots. Limited relief with SI joint injection. Second injection 3 months later into the spine did not help. Main pain is in the lower right gluteal and upper hamstring, and sometimes pain in the left upper hamstring and glute. Would love to be able to continue playing pickleball, be active, and not have surgery. He is 69 years old. Okay, Dale. Ronald asks, says, I am 84 years old. My back operation was last March/April. Went to a particular doctor for pain treatment, took as many as 5 gabapentin tablets a day, but still I am very limited in my distance walking or even walking still. Maybe standing, I'm not sure. Take up to 6 Tylenol per day and making no progress without lots of pain. PT does not help. Any suggestion to feel normal or close to it? I used to walk 2 to 5 miles a day without pain. Used to play lots of tennis, but now I am just doing no walking without pain and tolerate as much pain as I can to walk 1 to 2 miles a day with a rollator only. I'm not sure what that is. Maybe that's a rolling walker. I'm not sure. Any other suggestion would be appreciated. Thanks. The back surgery relieved pain but did not spare the pain, so I'm not sure what that means. Vera asks, Are there any stretches, exercises that should be avoided with a moderate-sized bulging disc in the lumbar region? Should one engage in exercises, stretches with back pain? Are there any stretches, exercises that should be avoided if there is a moderate-sized bulging disc in the lumbar region? Not necessarily as far as I'm concerned, Vera, but we'll get into some more detail in a little bit. So this one's from Mary. I have an ongoing nerve pinching pain in my left lower back close to the hip area. However, I do not have any pain down my leg. The sudden nerve pinch happens mostly from sitting, usually in a soft or lower surface chair, mattress, toilet, and sometimes when I reach forward to touch my toes. The pain is always unpredictable and sudden. Even after 10 physio and 5 chiropractic sessions, the problem still lingers. I was told it is not sciatica or piriformis. Chiro treatments seem to help, but we still haven't been able to pinpoint the source. Would you be able to help shed some light, perhaps? Yes, I think I can shed some lights on that, Mary. Almost there, folks. Juanita asks, I have a side bending issue. And folks, a side bending issue, and we're going to talk about this in just a second, is when one side of the ilium is up and the same side of the rib cage is down, creating what looks like a side bending, posture. So Juanita must have absorbed some of my information from at some point. All right, because that term is not that whole pattern is not even identified in physical therapy, much less the term side bending issues. So I can't remember whether I finished her question, but when I do the exercises for this condition, they really hurt. So this is a sign, Juanita, that they're not the right exercises for you, and we'll talk about that. Will this subside with continued practice? No, because your body is already telling you that it hurts, so stop that. All right, this one's from Gloria with stenosis, so yet another stenosis question. In L4, L5, I'm tightening my core with exercises I see on YouTube with PTs. What else can I do? It affects my ankles and feet, very healthy otherwise. Okay, all right, so a lot of questions. The bulk of all of the questions are about back pain. And one of the reasons this is happening is because I believe in medicine that we are really misunderstanding back pain. If we were doing really well with back pain, we wouldn't have over 600 million people around the world suffering from it, and that number rising every day. This means that we are not doing a good job in medicine. It is not the patient's fault. It is the fault of how we're trained to address back pain and, frankly, other pain in the body. So I went over this at the beginning, that most of these people have been addressed as from a component standpoint and not from a system standpoint. So let's talk about systems in terms of back pain. I'm going to give you a couple of ways to test yourself. But again, all of the tests I'm recommending are already on my pain pattern series of videos on YouTube. So please watch those, because I'm only kind of going quickly through them here because I've already put them in so many other places for free. So I just want to guide you to where you need to go. All right, so what's going on with back pain? So pain, like anywhere in the body, we need to understand why you're having pain. And so what the tests are that you have been undergone, x-rays, MRIs, orthopedic tests, whatever, are identifying specific tissues, but we need to identify patterns of problems that are systemically breaking down your body. The first test that I do with anyone with back pain is I determine whether they have an extension or a flexion problem. An extension problem simply means that the back is too arched, or there are too many forces pulling their back into an arch, and that arching is causing their pain. A flexion problem is the exact opposite, that their spine has too little arch, or there are too many forces trying to reduce the arch of the spine, which is then causing their pain. And not only pain, but I believe that these forces are also causing the structural changes that you're seeing on MRIs, x-rays, and so forth, like arthritic changes, disc changes, nerve irritation, all that kind of stuff. All right, so here's the quick and easy test that you can do to determine first whether you have an extension or a flexion problem as part of your pain pattern. All right, so you're just going to lie down on your back on the floor, and I say a floor because a firmer surface is better. It gives you more feedback into how your body is responding to this test. If you can't get on the floor, then of course do it on your bed, but just know that you're not going to get as strong feedback from the test as on the floor. So you're going to stay here for 30 to 60 seconds, and you're just going to see how does my low back feel. Does my low back like this position or not? And then after 30 or 60 seconds, you're going to bend your knees so your feet are flat on the floor. And if that doesn't make any difference in your pain, then bring your knees up to your chest and hug your knees and see if that makes a difference in your pain for another 30 seconds or 60 seconds. So one of these two positions is going to change your pain, either legs straight or knees bent. So which is it? And so if your pain increases because your legs are straight, well, what's happening when your legs are straight is that your back is arching more, all right? And so therefore your pain must decrease when you bend your knees, which means your back is flattening more. So if your back is arching more, for instance, if you have more pain when your legs are straight and less pain when your knees are bent, that means that you have an extension problem, which means that you have too much arching in your low back, because bending your knees is flattening the back. If you want to test that, just lie there and bend your knees and you'll feel, oh yeah, my back is flatter to the ground, and it does feel better in this position. So that means that you have too much arching of your spine or too many forces pulling your spine into an arch. The opposite is true. If your back feels better with your legs straight and worse with your knees bent, then you have a flexion problem, which means that your spine is too flat, and it's saying that it wants more arching. Flexion problems, in my experience, seem to be correlated to acute disc episodes, not chronic disc problems, but acute disc problems. And this is why often disc-related pain goes away on its own in a few weeks, is because we naturally arch our spine when we stand, and so if you have a flexion problem, just standing will start to relieve your pain. All right, so I'm going to talk mostly about extension problems because that is the bulk of what chronic back pain involves. But if you have a flexion problem, the one exercise that you need to do is that propping yourself on your elbows exercise that probably every therapist has already given you. What that does is it arches your back more and it helps correct the disc bulges or whatever irritation that's causing your pain. What you also need to do when you're sitting down is you need to sit at the edge of your chair at the front and maybe even raise your chair so your knees drop down. And what that will do is it will tilt the pelvis forward and help arch your back, which will then reduce the strain to your spine. So that is about as deep as I'm going to go with flexion problems, because in chronic pain conditions, they are so uncommon, and most flexion problems resolve themselves in the first few weeks after you have that acute disc issue. All right, let's move on to extension problems. What's going on here? So we now know, and you just tested, that you have an extension problem, and that means that your back has more pain when it's arching. By the way, spondylolisthesis and stenosis diagnoses fall into this category because back pain increases with arching in both of those populations. All right, so those people need to learn how to flex their spine more or remove the forces that are trying to pull their spine into more of an arch. All right, so let's talk about this from an ergonomic standpoint first. Those people with extension problems, if they are sitting, typically what they need to do is put a pillow or two behind themselves when they're sitting in a chair to bring the back of the chair up to them, and that they can then relax into the pillows and signal their spine to reduce its contraction of these spinal muscles. The other thing that they'll want to do is maybe lower the chair more so that the knees are slightly at or above the hips, which will throw the pelvis back and flatten the spine. And this is another reason why you want those pillows there, so your spine has something to flatten into and hold itself up. If you don't have the pillows, then you'll be straining to remain upright when your knees are higher like that. So this is a really easy ergonomic fix for a lot of people. So what we're primarily talking about here right now are people with central back pain or chronic back pain that's not on the one side or the other. We'll get to the people who have chronic back pain on one side or the other, or sciatic pain down one leg, or SI joint pain down one leg in just a little bit. But bear with me, because the extension problem is often on one of the patterns that's contributing also to that unilateral pain pattern. All right, so we've just covered ergonomics, what you need to do with that, and of course that's found in my home programs, and I think I talk about that in my pain patterns book too. So what other thing would cause your back to hyperextend or be extended? So I want everyone to stand up right now and just stand there and listen to me for the next minute or two. All right, so it's important to understand that one of the muscle groups that's pulling your spine forward is the thigh muscles in the front of your thigh. Now, these cross the hip joint and connect into the pelvis. So when they are tight, they are pulling the pelvis forward, creating arching of the spine. The thigh muscles can be symmetrically tight, or they can be asymmetrically tight. Therefore, they are introducing a rotational torque into the pelvis, which then plays out as sciatic pain or SI joint pain or one-sided back pain because of that tightness. So to stretch this out, you want to lie down on a firm surface, bring both knees up to your chest, and lower one leg down over the edge of the table and stretch out the thigh muscles. The opposite knee that's up to your chest needs to stay near that chest to protect your back and spine. Hold that stretch for 30 to 60 seconds, bring the other leg up, reset your back and pelvis, and then lower the other one. Do that twice on each side each time you do this. All right, you should notice an almost immediate change in your back pain after you do this stretch if your thigh muscles are tight. All right, of course, that is found in my pain patterns book and in my home programs. I hate to sound like I'm a broken record, but I just want to emphasize that this information is out there and has been out there for a long time, and you can find it for free on my YouTube channel if you just do a little digging around out there. All right, so you've been standing here listening to me now for about a minute or two. Now, what I want you to notice is please don't change anything about how you're standing right now. So what I want you to notice is, are you locking one or both of your knees straight when you're standing? And if you're not sure, I want you to unlock both of your knees. Feel what just happened to your back. And if you're not sure what just happened to your back, lock your knees once more, and you'll notice that when you lock your knees, your back arches more. This is one of the most pervasive and common habits that are causing people's extension-related back pain. I can't emphasize enough how important this is. In fact, I have solved many chronic back pain cases just by getting people to unlock their knees. One of the ways I do this is by simply putting a piece of tape on the backs of the knees, and we do this when the knee is bent, so that when they walk and they try to lock their knees, they bump up into that tape, and that reminds them that they're locking their knees. Changing this habit can go a long way to solve extension-related pain. And so for those of you with spondylolisthesis and stenosis, this is one of the things I would recommend paying attention to, is unlocking your knees when you're standing and walking. And I've talked about, I think, gait in the hip pain questions of this video, so hopefully you stuck around and watched that part too. All right, so that is a biggie. I can't emphasize enough. So what I've given you is a habit correction, that of unlocking your knees, and an exercise, that of stretching the thigh muscles, and especially if they're asymmetrical. This should go a long way to reducing your extension-related pain. Now, what about those people who are complaining of one-sided pain on one side of their back, one side of their butt, one side of their SI joint pain? Whatever practitioner has identified as the tissue that's irritated, it doesn't matter. If it's on one side, you likely have a side bending problem, which is what Juanita mentioned in her question. A side bending problem means that typically, let's say you have right-sided back pain, typically then the right pelvis would be higher and the right rib cage would be lower. And what this does is it creates a little crease on that side of your waist. So the easy test that I have in my pain patterns book for you is to simply have someone take a picture of your spine with your shirt off from the back. notice whether you have a crease on the same side of your sciatic pain on that leg, or hip pain, or SI joint pain or back pain or whatever you have. If it's one-sided, see if you have a larger crease on that side. If you do, and then if you look really closely at that picture, you might notice, oh yeah, it looks like my hip is higher on that side. And if you see that higher hip, likely your rib cage is also lower on that side. Now, in a case where this rib cage would be lower on the opposite side is in congenital scoliosis. So this is a functional scoliosis. I say that because how you are using your body is causing this side bending pattern. However, congenital scoliosis is when you have a pelvis higher on one side and a rib cage lower on the other side. That is the congenital scoliosis. But even congenital scoliosis has functional roots in how fast that scoliosis advances and shows up in the body. So just because it's congenital, meaning you're born with it, doesn't mean you can't do anything functionally to offset it. In fact, there's a method called the Schroth method that's very common that addresses congenital scoliotic pain. The stuff that I have in my program also fixes congenital scoliosis, but it's not specifically for congenital scoliosis. So if you want to go deeper with that type of information, feel free to do so. But just know that I've helped a lot of people with congenital scoliosis given this information, because it has functional roots in it too. All right, so what is happening with a functional scoliosis? Why is this occurring? It's in 80 to 90% of the cases, it's because of a problem on the same side of the body. Whether it be the foot, the knee, the hip, it doesn't matter. So what is happening is you are compensating around that problem, and then creating this pattern where the pelvis is elevated and the rib cage is depressed. Why would that be? Because the muscles that would elevate the pelvis attach into the rib cage and therefore also pull the rib cage down. The other common pattern that creates this is if you're walking and you step on that side and you are just collapsing on that side. And if you want to see this in action, I've posted lots of airport walking videos on my YouTube channel showing this exact pattern. So please watch those videos. I can't tell you, I've created so much stuff for you guys to pursue and look into. I really think that you're going to solve your pain if you just follow this stuff. But I've created these airport walking videos to show you people walking in an airport, their walking patterns that are side bending patterns. All right. So if you want to see what that looks like, watch those videos. Now, if you want to see what is happening to you, once again, get someone to videotape you, hopefully with your shirt off, and watch you walk, and you'll see that you are collapsing usually on the side that you're having the pain on. It's really fascinating because most people aren't aware that this is even happening until I point it out, and then they can't believe they didn't see it before. So please take a video of yourself to objectively look at it yourself and not rely on someone else's vision, and you'll see that side bending problem. Especially if you have a crease on one side, you'll see that crease deepen while walking. And so many of the questions on here are saying that their pain is increasing when they're standing or walking. And this is why it's happening, is because they're standing and walking and reproducing the pattern that's crunching their spine and nerve roots, causing the sciatic pain going down their leg. Especially for the first woman who asked about her foot pronation causing her back pain, should she have the surgery for her foot to solve her sciatic pain? Well, again, that foot is only a small part of the chain. You can fix this whole pattern and still have a pronating foot. Just because you have a pronating foot doesn't mean that you're destined to have this whole pattern. You can change it because you can control your body. Now, let's say that you've taken the video, you've watched yourself, you're just like, oh my gosh, this is me. This is exactly what I'm doing. I'm collapsing on that side in some way. Maybe your hip is jutting out, maybe your shoulder's dropping down, or something like that. So how do we fix that? Well, what you'll do is you'll just let's say it's happening on my right side. I'm going to put my right hand up in the air, and I'm just going to walk with my right hand up in the air. Now, whenever I step on my right leg, I want to reach my hand up as high as I possibly can to stretch that out. What is that doing? Well, it's lifting my rib cage off of my pelvis. But what it's also doing is by keeping the rib cage off my pelvis, I'm forcing my hip to learn how to work correctly and hold my body up. So you don't have someone there right now who can measure your pelvis and rib cage. But I can guarantee you, every time I find someone with a side bending problem and I had them do a reaching while walking to correct it, within 5 to 10 steps, the pelvis is level, the rib cage is level. What does this tell us? It tells us that the side bending problem is due to a walking pattern. Because walking is fixing it, that means that it's due to how you're walking. Trust me on this. So if you can go around for the next couple days with your hand on your head or up in the air whenever you stand up from a chair, and if your glutes are turned off, and you can even do it while tiptoe walking to get the glutes to turn off and fix the side bending problem, then you'll start to fix your gait pattern that's surrounding this, and you should feel almost an immediate decrease in your pain. One of the causes of side bending problems, guess what, is poor gluteal performance, which is what we talked about in the hip pain section of this video. And guess what, if you're locking your knees, like what I mentioned in the knee pain section, then this is also turning off the butt and therefore contributing to your side bending problem. And if you have a pronating foot, like we mentioned in the very first question, that can also cause the whole system to collapse, and you compensate by jutting the hip out or dropping that rib cage down. And by the way, if the rib cage is dropped down, guess what sits on the rib cage? The shoulder blade. And so if you have a side bending problem and your rib cage is depressed, that means that your shoulder blade is depressed. And remember, depressed shoulder blades are what causes almost all shoulder, neck, and headache issues. So this is how you can link the foot all the way up to the head and neck. And I even mentioned this, I call it functional linking in my pain patterns book and describe that. So I hope that gives you some ideas of what to do. All right, the walking, I've given you a walking pattern to fix the side bending issues. What is an exercise that will help you fix it? Well, again, this is in my pain pattern book and I have it in other YouTube videos, but I do something called a standing hip strengthening exercise. And I'm going to show it to you right now. So basically what we need, the problem is that you're collapsing on one side of your body. The knee is likely locking, the hip is jutting out, the rib cage is collapsing to some degree. So we need to train your body to be able to stand up without that happening. So what you're going to do is you're going to stand on one leg, and if your balance is really poor, you can put a stick in your hand, but it needs to be in the same hand as the leg that you're standing on. But use the stick as little as possible to force your body to strengthen itself. All right, so our goal is to be able to stand on one leg and not collapse. It's as simple as that. So if you can stand here for 30 seconds without collapsing, if you're not sure if you're doing it right, look at your good side that isn't painful, and you'll notice that the good side, there's no collapsing or no struggle to fight collapsing at all. And then when you go to your painful side, you'll see that you really have to work, or your shoulders shift over, or your hip is trying to jut out, or all sorts of things are happening. So this is what you need to work on. You need to get that painful side to look like the non-painful side. So that is your practice. Your first goal is to be able to stand there for 30 seconds with it being perfect. And once you reach that goal, then you can move on to level 2, which is simply moving the leg out to the side a few inches and back for 15 reps, still staying upright, because now we're introducing even more strength challenge to this hip. And again, you can do this with your hand on your head or hand up in the air if you want to. Really lift that rib cage off of you and force the hip to do the strengthening. So let's say you're able to now to stand there tall and you move your foot in and out for 15 reps for 3 times on each side. No problem. Okay, then we add some resistance. And what we'll do is we'll just get a little exercise stretchy band. You step on this with both feet. You bring it up and you do the exact same thing. You stand on that leg, the knee is soft, you're standing tall, and you move that foot out and in. And now the tube is giving you some resistance to make it even harder for you. Again, 3 sets of 15, and this should strengthen this lateral system that's collapsing and creating all of this one-sided back and sciatic pain. So that gives you both a habit to fix and then also a strengthening exercise to fix it too. Finally, I have a final question about fibromyalgia. The question is, how does one differentiate between the tender painful areas due to fibromyalgia and other tender painful areas, especially when trying to determine whether it's weak glutes, tender bursa area, tight thigh muscles, hips, etc. Thanks for your work and your books. Paying attention to how I walk and stand has virtually eliminated my bursitis. Well, I'm glad to hear that. So I don't have an answer for fibromyalgia per se. I don't think anyone really understands this condition. My approach as a physical therapist is to understand the biomechanical stressors acting on your body. That's what this whole video has really been about, is understanding how your body works as a system, where those problems lie, and how to identify them and solve them. I have found that with a lot of my fibromyalgia patients, if I can solve the biomechanical issues that are creating strain to their joints and muscles, a lot of their fibromyalgia pain goes away, but I am under no delusion that I'm curing fibromyalgia. I'm just fixing mechanics, which you found by fixing your gait pattern, you solved your bursitis. And I would wonder if your bursitis was identified as perhaps a fibromyalgia point prior to you solving it. So my best advice to you is to find the biomechanical stressors of your body, solve those, and then that hopefully will get rid of a lot of the stressors creating these tender points for your fibromyalgia. If you found these answers helpful, remember this is just the tip of the iceberg. Chronic pain usually comes down to hidden systems problems, and that's exactly what I cover in my book, Pain Patterns: Why You're in Pain and How to Stop It. You'll also find guided home programs on my website if you want step-by-step solutions you can start today. Almost all of the tests I mentioned in this video are also on my YouTube channel. In fact, I've created a series of short videos that walk you through each chapter of Pain Patterns, like I've mentioned before, featuring all the tests from the book to help you pinpoint where your system is breaking down. It's all free, and my channel is packed with other videos that may already answer your questions, so take some time to explore. Finally, if you'd like to get your answers quickly and want me to put it all together for you, simply go to my website and schedule a virtual or in-person appointment. I'd love to help you directly. Don't forget to subscribe and click that bell so you're notified when I drop my next video. Thanks for watching, and I'll see you in the next one.